So just some notes, please, guys. Again, if you have any questions, please write it in the chat session, and or raise your hand, the hand symbol. Please, everyone is encouraged to ask questions and interact to make this session helpful. And again, just because I wasn't recording earlier, thanks Juan for reminding me. I just introduced Mohamed again, who is a local consultant from Norwich, and he's presenting on mastering techniques for FRCS Viva. Over to you now, Mohamed.
Oh, thank you Faraz for introducing me and for this amazing project everyone is sharing to do. So I'm Mohamed Imam, as you said, an upper limb surgeon from Norfolk and Norwich. I'm going to give you a presentation today about mastering the techniques, which is really important. We all get this message, and after having that message, you have a short period of initial elation that will quickly followed with the fear that you now have to prepare for section 2. And I think that's really important to master your techniques, because you've demonstrated the knowledge in passing part 1. In section 2, and I'm talking about the Viva part here, it's all about technique. What I'm going to tell you is actually experience, my own experience I've got from examiners that I've done practice with, experience from the exam itself, experience from senior colleagues, from my colleagues, from other mentors here that I prepared with more about 2 years ago, and also these experiences I think is crucial to master for your Viva. I think, you know, the first part of this presentation is mainly for those who are doing part 2 in a few months' time. Second part is for everyone, especially those who are doing the exam in a few weeks' time. Part 2 is a tough assessment of the curriculum set by the GCST and the specialist advisor committees. And so I think personally, which is helpful as well, is the first thing you should do is to read the ICP syllabus. It is almost 300 pages long, and any topic on the syllabus can be covered in the exam. So therefore, you should have a broad range of knowledge to pass, rather than the depths of knowledge. And we'll discuss that in details. The logic here is to understand what is the exam about and what they are assessing, basically. You hear stories about candidates being marked down for wearing wrong ties or simply because an examiner didn't like them. Although in reality, this perhaps was once true. However, now the exam is no longer an unstructured chat anymore. The modern exam has structured questions, starting with an opening stem, followed by more detailed questions. And I know colleagues who are very good surgeons, who are very good, who are experienced and knowledgeable, and they failed, and others who are less knowledgeable and less competent who passed. And it's simply because it's all about the technique. Basically, this exam is testing a day 1 consultant, and this is a crucial tip for this exam. You're a day 1 consultant in a DGH. So when you are sitting at that table, these 2 consultants examining you, they are your colleagues. You are discussing with your colleagues in a trauma meeting in a DGH you started in as a day, in your first week. It's not MRCS. You shouldn't waste time on things like this X-ray looks so and so, AP and letter views, and we'll go through it by time. So the key to passing here, first key, is to answer the questions as a consultant, not as a reg. Examiners want to know what you would do if you saw the patient in a clinic, if you saw this patient on a post-take ward round, and the decision you would take in your clinic or in an MDT meeting. So the answer to every decision-based question should start with, I would, not you could. You shouldn't say the options are, or my consultants would do. Do not refer every difficult scenario to a colleague. Some stations where there is a bone tumor, that should be managed in the bone sarcoma unit. Well, I'll go through that in detail. But remember, this is an exit exam. You're meant to be able to cope with these things as a consultant. If you were the consultant in a small DGH, you should be able to diagnose and accurately and urgently manage neck fascia. You're not required to do a hemipelvectomy on someone with a massive osteosarcoma of the pelvis. But all emergencies is a must. So the Viva here doesn't test your knowledge. It tests your ability to convey the required information to the examiners in a confident and coherent way. So one important thing, and I was told this by two different examiners, this exam is testing your high order thinking. Passing this exam is all about the technique. People who fail, again, do not fail because of lack of knowledge. It is like a game. You need to learn how to play that game. You need to be so it's very well to quote 10 papers worth of evidence, but if you cannot make a decision, you're not ready to become a consultant. They will give you some time to prepare to become a consultant because you, as I said, you've demonstrated your knowledge. So you're expected to process information given and formulate it. So looking at this here, you know, like what is the higher level of thinking here? So, you know, I would start this by saying this is a Monteggia fracture dislocation. I wouldn't waste time saying X-rays look so and so. I would say this X-ray show Monteggia fracture. In discussion, he will ask you at some point, you cannot reduce it. Then you would say, I'll check my ulnar fixation. You still can't do it. Then the examiner will ask you, you should mention there might be soft tissue interposition. An example of higher order of thinking here is that you would say, this is immature bone, the head is not well formed, I'd like to check the other side, take another radiograph of the opposite elbow to make sure this is not congenital dislocation of the radial head. If it is well formed, you should think about that as well. You can say, usually I would be worried if I cannot reduce it, I'm going to do another X-ray, another radiograph of the opposite elbow to make sure it's not congenital dislocation. However, here I can see the radial head is well formed. You know, you're not going to do that in real, you can do it in real life. I did it before in real life, but the thing is, I think you should mention it. So mentioning that makes you stand proud in the candidates to the exam. And then the one thing of one demonstration of high order of thinking. And you know, doing more practice will make things perfect. Performance here can be achieved only by practice. And that's a general advice everyone have told you. So I think it's really important to practice in a group. And this is already published evidence. If you practice for the Viva and clinicals in a group, the chances to pass is twice. Ideal number, I would say, is 3. But remember, this advice is always personal issue for each individual candidate. So what works for you might not work for me. I think when you do this practice, especially like settings like here, it's really important to examine to practice in an exam scenario. If there is an examiner in your region who's happy to conduct a practice Viva, then jump at that chance. Don't waste it. He or she knows the structure. He will tell you all the tips if possible. If also discuss with, you know, do this practice with your consultant as well, because although he might not have the time to do a proper revision session, but it would be helpful, you know, to make him ask you questions, and you should learn how to get used to answering questions on wide range of topics. Finally, practice with your partner, with your dog, with your mirror, with practice until makes perfect. Also, a general advice on long-term plan, I think you should, especially if you're not a trainee, you should do more and more courses. Although some of them are expensive, but I think you should ask for a recent feedback. Some courses are well known and they actually have good reputation because they are dedicated, you know, these institutions are dedicated in giving these courses. There are different websites, there are different books, there is no it's actually all about feedback you get, but I would advise doing more and more courses. On the day of the Viva, it's really important when you sit at the Viva table, you should sit confidently, upright, with your hands on the table. Don't, you know, you should demonstrate confidence. Do not cross your arms, do not slouch. Most examiners will offer you a handshake. If so, do the handshake. If they do not offer, just it's best to sit down. Smile at them. They will be bored. You have to come as a pleasant and confident candidate who knows what he or she is saying. I would, another good advice is to avoid odd ties, odd shirts, as simple as it gets. And you will be asked by one examiner, just look at them and look at the other examiner as well. On the day, if you can afford it, stay in a nice hotel rather than the cheapest one available. The exam is expensive. You've paid a lot of money. Don't wait, find the decent hotel. It will make a huge difference to your, ask the receptionist, which I've done, when you book the hotel, to find you a room in a quiet part of the hotel. Tell them that you are sitting an important exam. You don't want to sit in a room overlooking the back streets where there are nightclubs and people shouting at 1 a.m. I personally also think it's worth finding a hotel, but not where the Viva is going to be, because that's usually where the examiners are staying. And if you're sitting for breakfast opposite to an examiner who gave you a tough time in clinicals yesterday, that wouldn't be helpful. However, it's up to you. What is that exam about? It's about safe surgeon. You keep hearing that word all the time. You must be safe in your answer. When several options are available to treat a patient in your Viva, start with the most widely practiced option that has the greatest evidence base. You can then talk about new techniques, pros and cons, but you do not want to come across as a maverick. It's also unwise to get into an argument with your examiner, and you shouldn't be operating and describing surgery you never seen before on that day. And if you don't know what you're talking about or you haven't done it yourself, or you can always say, I have no experience with this type of procedure, but the principles of surgical intervention or non-operative intervention here are so and so. And because if you will become as an honest candidate, however, they will know anyway. If you haven't seen it or done it before, it's easy to get it. You are an orthopedic surgeon with 10 years experience sitting in front of an orthopedic surgeon with 30 years experience. So it's obvious. As soon as you sit down, the questions will begin. Listen extremely carefully to every question. Pause for a second or two. Digest what you have heard. They will usually ask a very specific question. If you answer a different question, you are about to lose the examiner. Most people struggle here because of the technique. So your last word is the examiner's first word. So make sure when answering a question, avoid saying something you know nothing about it. So if you say, I'm going to do carpal tunnel decompression, he will ask you how to do a carpal tunnel decompression. I'm going to, I think this might be osteosarcoma, tell me more about osteosarcoma. If you say a weird syndrome that you're suspecting, he will ask you about that weird syndrome. The examiners also are unlikely to give you feedback during the questioning. That can be difficult, especially if you're used to having notes and sounds of encouragement from colleagues or consultants while you're practicing. You must remember also that in order to aggregate marks, you will have to say, I don't know, because they will ask you a very simple question. You answer that one, the question will become harder and harder. And usually those who passed, they will tell you that they failed the exam. And those who failed the exam, they will tell you, most of the time, I've done well. I've answered every question they asked me. One crucial tip here also is drawing. Draw whenever you can. And that drawing should be as clear and big as possible. If you have the opportunity to draw, you should do so. Pictures tell 1,000 words. Especially if English is not your first language, you should, however, speak as you draw. It adds to your point scoring very quickly, and that was a tip I had from a gold medalist. We worked together. So he even exposures, he will draw the exposure. Anatomy, he will draw the anatomy, and that drawing should be simple, clear, big, so that both examiners can see. Simple, big, and clear. Remember that, and practice these drawings. And an important step, this is also important, that it takes the pressure off your shoulders, because when you are drawing, you're not looking at your examiner, so you're looking into the paper, so that will take you the pressure off your shoulder. Also, you've done visual and audio demonstration of your knowledge, which is really important. Another important tip as well, if you're shown pictures, radiograph, diagrams on an iPad screen also, do not touch the images. Just be professional, look and put it down. Use descriptive terminology. Also, on the day before the exam, sometimes also this is an important tip I would say. If you finish your clinicals, you shouldn't be worried much between your clinicals and your Vivas, because the Viva part of the exam takes place 1 or 2 days after the clinical cases. Half the time in between is very stressful, and it's very difficult to spend productively as you mull over your performance in clinical cases. So try to relax and take your time. Also, I would advise for Vivas in the last week before your exam, revise your basic sciences. And I didn't do any revision between my clinicals and Vivas. You don't have to do that, and that will just stress you more. So when you are sitting at your Vivas, one of the examiners will ask a question for 3 questions for 15 minutes, and then they will swap over. Remember, this exam is conducted by non-specialists. So, remember, a hip surgeon will ask you a hand surgeon. So the questions consist mainly of a default question, competence question, and advanced question. Say, as I said, when you start answering, you have to draw a mental checklist of what you are going to do. If he asks you, what would you do? Don't say, my boss does that. No one cares what your boss does. I would do 1, 2, 3. Why? Because 1, 2, 3. You can say I have good experience with this, but that's actually, your experience. There are surgeons who have done surgery, a specific procedure 100 times, and actually their outcomes are really not that good. So when answering the question, do not try to make up an answer if you really don't know. The examiner will see through this, and they will know immediately. So admit it. I have no experience with that, but principles of management involve 1, 2, 3. Also, you might not understand what they've asked you, what he wants you to answer. So ask him, can you please repeat that question, please? And ask him to repeat it. And before you answer, this was very helpful. Mentally construct a checklist of the main points you are going to make, and start your answer slowly. That avoid blurting out the first thing that comes out of your mind. And even if that happens, apologize and say, I'd like to retract that, please. And that's a valid, that's what we call damage control. And once you finished your answer, stop and keep quiet. Try to avoid the temptation to add extras at the end of your answer, because that might make you look as if you're waffling and can annoy the examiner. Also, if they bring you into an area you don't want to talk about, which is bad, tell them, I have no experience. Remember, the examiners there to pass a candidate. They want to feel that you're a safe consultant colleague. Also, it's really important here, with practice, there are common scenarios that come in the Viva, but you have to be prepared that 1 or 2 might come. In my exam, that was the last station, and you hear stories about the cut section in a brain. You can hear stories about all these odd scenarios and odd questions, but then don't panic, follow the rules, and it's a valid option. If they ask you a different questions that you don't know what they're talking about, or you have no clue what is that, then say, I'm going to discuss it with my senior colleagues. I'm going to check for guidance. I'm going to check for evidence. I'm going to check my local trust protocol, because that happens in daily life in every NHS hospital. An important thing also is, what is the evidence, and do you need to know papers? Yes, you do. You're not, we're not convinced when things is, they are not convinced when they hear people say you don't need to you don't need to quote the literature. Actually, you should be safe. Literature there is to differentiate between a 6 mark and a 7 mark or even more. So look, by quoting the latest journal articles is impressive, but not your examiner if you're quoting papers inappropriately. So, you have to know seminal papers in orthopedics, multinational, multi-center trials like DRAFT or PROFER, or all these trials, you should be aware of it. You should be aware of NICE guidelines. You should be aware of POST guidelines. And when you see one of the POST scenarios in your Viva, you should mention the word POST, because that's evidence, and you've cited evidence. Also, evidence is ideally cited when you say, I would manage this tibial plateau fracture with so and so. He will ask you why. You say, there is evidence published in BJJ 2012 demonstrating high satisfactory outcomes. But you shouldn't be quoting evidence for 4 different treatment options while answering a question. If you want to score an 8, the examiner would expect you have an excellent command of the literature. To score a 7, you should be familiar with the literature. But if you score a 5, such as literature doesn't really matter, as you're struggling to keep your head above the water, and you're not demonstrating you're a safe surgeon who can demonstrate safe practice. Another important thing is, you have to keep your examiner asleep while you're doing this examination, and that can only be done by using buzzwords they want to listen to. I'll give you a few examples now, but you have to remember things like NICE, boost, non-accidental injury, ATLS protocol, open or closed nerve or neurovascular assessment. If something is very obvious, you should be confident and say it outright. This radiograph demonstrates a posterior head dislocation because of these features. These features are 1, 2, 3. No MRCS, as I said. The marks aren't in finding that this is a head dislocation. Actually, if you cannot tell this is a head dislocation, you shouldn't be taking this exam. If you can see a Montegia fracture, mention it first thing, and then you can give a hint about it. Because to score marks, to score 6, 7, and 8, you should be discussing management in details in most scenarios. So in something like that, what are the buzzwords here? Montegia fracture, immature pain, immature bone, worried about non-accidental injury. In all pediatric, mention non-accidental injury. If you are good, say this is bad or type 1 injury. It looks like it might be an open fracture. And if you say, I'd like to know whether this is an isolated injury, give him the chance or her the chance to tell you, yes, it's closed or not. And if it is written in the paper in front of you, don't waste time. These 5 minutes are yours. And they actually aren't 5 minutes, because these are 4 minutes, because it will take some time to swap between different stations. So these minutes are yours. You should make the best benefit out of it. I would use, then you can show high order of thinking, as mentioned before. So you have to do the mental checklist and take it from there. This is a Gliese fracture. You're worried about this fracture. Why? Because there is a dislocation of the post-ulnocarpal and radioulnar articulation. If you're worried, say it loud. I'm worried because this is about the gravity of this scenario, and also I'm worried this is an open injury. He will tell you it's an open injury. I'm going to manage it according to boost guidelines. So you should mention Gliese, open injury, or skin at pearl at least. I'm concerned about the gravity of this injury. I'm going to manage it as per boost protocols for open fractures. I'm going to give antibiotics, tetanus prophylaxis, or this. If they don't want to read that in details, they will ask you to move on. And that's a very important step. We'll discuss it later. Then I'm going to discuss, high order of thinking here. You'd like to take another radiograph of the opposite to see how does distal radioulnar joint look in the wrist. And if you say something, you can say whatever you want. Remember, in these exams, there is no correct answer. There are wrong answers. There are few correct answers, but there is definitely wrong answers. So if you can say something, if you have a case of osteoarthritis in the hip and you'd like to use Corai Pinnacle, you can cite the NGR, you can say this is my experience, you can cite publications. So there is no right answers, because it's the 2 examiners in front of you. One of them might be using all cementless, someone might be using all cemented. However, I would stick to the most safe answer that you can validate. This is a radiograph of a child who's like 12, he's an unweight bearing child. You can cite all the evidence in the wallet here. You can talk about it in details for half an hour. If you don't say NAI, that's a 4, 100%, that's a 4. So this is a buzzword. You should mention it here. Actually, personally, I would mention NAI in all pediatric fractures, just to be safe. You wouldn't be marked negatively if you say so. Here, you should say my priority is to ensure that child is in a safe environment. If you're considering NAI, you should mention nice guidance on NAI and how to diagnose NAI. He will ask you questions, whose responsibility to diagnose NAI? It's everyone's responsibility to diagnose NAI. And so you can cite the evidence, because this is proper evidence that has been published and it's big trials. Published in BMG. As I said, you should always be aware of the trials published. Here, you can, buzzwords you have to mention, the large health sacs, defect in the humeral head. So there are buzzwords for everything. You should here also mention the neurovascular assessment. Neck fascia, life-threatening condition, you should express your concern. You should mention that you're worried here. They can show you a picture of cellulitis. That's fine, but you're not going to be tested on cellulitis in an FRCS scenario. So you should be worried about life-threatening emergencies like compartment syndrome, neck fascia. All what you need to know about neck fascia is about 10 buzzwords. The Lennox score, it is a life-threatening, mortality 30%. The definitive treatment is urgent and radical debridement, and you have to, demonstrate high order of thinking here by saying, I'll discuss with the patient prior to the surgery the possibility of amputation. That can demonstrate high order of thinking. And when you are demonstrating your knowledge here, as I said, you would say, I'll do bloods, and then you mention the Lennox score bloods, because as per the Lennox score, because it has a positive predictive value of so and so. So what is really important here, and that affects most examiners on a long day, if they ask you a question, you should listen carefully. It's not during group practice. You should become familiar with the process of listening carefully to the wording of the questions asked and answer accordingly. If you ask, how would you manage that? Don't say the treatment options are. That's, even me telling you that sounds silly. But if you ask what are the treatment options, you answer that question. If you ask how you would manage it, I would manage it by so and so. So examiners are looking for answers that illustrate understanding and decision-making process, not simply regurgitating material memorized from books or from courses. There is a different lecture on the YouTube channel on mastering different Viva scenarios, but I'll just give you small hints about the 4 major scenarios. So in basic sciences, this is an easy scenario. You shouldn't know in depth. Actually, you should know. It's you should know about everything. And when you are doing the basic sciences, you should teach the examiners. It's really important that you're teaching them. And remember, if they increase the difficulty of the questions, that means good outcomes. And in the exams, there will be 2 or 3 anatomy related questions or approaches type of thing. So this is a good station for marks, and especially remember, examiners are orthopedic surgeons who read these 2 or 3 topics in the last couple of days, because they are going to ask you about it. And one also important trick that I've used as well, when you're doing like stress strain curve, Google write stress strain curve on YouTube and see, you'll find few videos describing the stress strain curve. When you find these videos, you can hear a few tips, that demonstrates that you know something more. Broad knowledge is really important here and required. And again, draw whenever possible in this Viva station. In the trauma Viva, I would say that's the only Viva, the in-depth knowledge is required. Because you're a day 1 consultant in a trauma, in a DGH. You should know back to front how to manage hip fracture. You should know everything about ankle fractures. It's not optional to miss a patient with compartment syndrome, because when an examiner writes 4, he or she intentionally want you to fail the exam because he doesn't think you're a safe surgeon. So here, high level of knowledge is expected from day one consultant. And also the importance of the trauma thing. If you are a consultant on call, you have to take that decision during the night, whether what to do for a compartment, how to manage it, what is the protocol. You know, you're not expected to manage a scoliotic patient during in the middle of the night, but in trauma, it's really important. And also remember NAI, non-accidental injury. Remember post guidance, nice, and have a bespoke clinical approach for every patient, and discuss it as if you are in a fracture clinic. The minute you forget you are in an exam and you start and you practice or perform as if you are in a clinic, in a fracture clinic scenario or an emergency scenario, you will do better. There are common scenarios that come most of the time. You should learn and practice these more as much as you can. And emergencies like compartment syndrome, neck fash, you know, leg screws, principles of fracture fixation. You can't be a fellow of the Royal College of Surgeons in Orthopaedics and you don't know basic principles of leg screwing, tension band, and management of emergencies in orthopedics. And you can be asked supracondylar fracture humerus in a kid, in a pediatric Viva, you can be asked that same scenario in a trauma Viva. So, but they will come one way or another. Controversial things like grade 3 ACJ disruptions, you should have one, you know, you should have a protocol in your mind. And if they tell you, you know, like this is grade 3 ACJ disruption as per Rockwood classification, he will ask you, then, as I said, last word, first word. Last word, he will ask you what is Rockwood classification. Then you draw a clavicle, draw an acromion, say grade 1 is disruption here, grade 2 is sprain here, grade 3 is less than 100%. So when you are drawing, you're adding to your marks. And anatomy is and approaches here. You know, it's really important to know your anatomy because you are a surgeon. Sooner or you are a surgeon. And anatomy isn't a variable. Anatomy wouldn't change. You can change any other thing, but anatomy is not the variable. And also, you know, tell a story from your perspective as a surgeon. So I would do, having prepared, marked, and consented my patient, I'm going to position my patient in a pitch chair position. I'm going to do my deltobectoral approach by identifying the coracoid, marking my incision. I then going to do do my approach in that technique. I usually swipe my finger underneath my deltoid, telling it in a story. It's much better than saying I'll position so and so, interneural plane is between so and so. Tell it as a story, and then my approach, my superficial dissection will be between X and Y, and I'll be worried here about the vein or the nerve or the vessel. I'm going to take it to that direction or the other direction, tell it as a story. And actually you can summarize all surgical approaches in 2-3 pages because all what you need is position, bony landmark, superficial dissection, deep dissection, and no a trip or two. Cross sections is really important. You should know them. You can be shown that in an exam. Usually that's a compartment syndrome. So be familiar with these cross sections. In other pathology, actually it is, you can be asked about everything, anything, just stick to the rules, stick to the basic principles, cite evidence whenever you can, and discuss management. In other pathology, you should be discussing management in most scenarios. There are common adult pathology like ACL disruption and you know, the adult pathology can be asked anything. Paeds, it's easy. Because you're not required to have in-depth, but there are certain scenarios that you should know back to front as well, can include any trauma. And you should also be here, you should mention that you will be discussing stuff with the parents or guardians. In hands also, it is the same, don't make things up. As I said, there is a detailed presentation discussing different scenarios. And finally, you are a day one consultant who's confident and he knows and you know what you're talking about. Just stay calm, do not panic, and stick to the basics. And practice is the key answer to everything. But as I said, it's all about knowing the game, mastering your technique, you have the knowledge. Knowledge is really a problem. If you don't have the knowledge, you wouldn't have passed part 1. If you don't have the knowledge, you shouldn't be setting for part 2. But as I said, it's all about the technique and playing the game to be suitable to join the club. And you should make your examiner confident that if his mom or sister had a fall outside your DGH, he's happy for you to do a hip hemiarthroplasty for his mom or relative. Thank you.
Thank you, Mohamed. That's excellent presentation. Thank you for all the experience you gave us from your exam knowledge and from the experiences you had. I think it was extremely useful. And I have to say, when we were doing the exams, we didn't have access to such amazing advice, to be honest.
Yeah, and definitely, and as I said, actually, this is what separates, that's, these techniques and simple stuff is what differentiate, but a 7 from a 5, and it's really crucial to collect as much marks as you get, and these tips are available to some candidates long time in advance. It's not available for everyone, and that's why we try. That's why Orthopaedic Fellowship mentor group is formed. Then.
Thank you, Mohamed. I like particularly like the fact you emphasizing the necessity of talking like a first day consultant.
Definitely, yeah, definitely,
and that we are not juniors anymore. So you say, I would do this, not we would do, or in my trust they would do this, or in my department they would do this. I would do, and the reasoning behind it, you back it up. It's very important, this kind of attitude. And little things like what I liked today is those examiners are extremely bored. They're fed up. And when you come into their table, they want to see a candidate who lifts the spirits up. Someone who's smiling, confident, pleasant, who gives them a little bit of joy and lift the spirit up. They don't want someone who comes look like defeated, bored, and scared or nervous. They want someone relaxed, confident, smiling to them. Just give them a little bit of good time also. They will like that.
And actually, it is easy to demonstrate it, and you can be easily picked up because, like a few members here in the group have been faculty in a lot of courses, and you can tell that candidate doesn't know what he's talking about, either how much he's worried. And also you can tell, whether you're confident in what you're saying or not. It's not what you're saying, it's the way you're saying it, but don't say stupid things. And yeah, you're definitely right, Firas. I can't agree more.
And also, staying in a nice hotel before the exam is very important. It's costly, unfortunately, but I think, you hear those horrible stories of those people who stayed in a very noisy room and couldn't sleep overnight, and that can't be good.
Yeah, definitely.
And I think I have some of my colleagues who didn't have a good night experience before the exam, and that didn't reflect well on them. So, unfortunately, the exam is run in a very expensive hotels normally. Well, I think you have to account for that in your budget for it.
Yeah, definitely. And this is really important because that thing I've mentioned, if a hotel with a nightclub underneath it, and especially you do the clinicals on Sundays, so having a busy night on Saturday night, till 5 a.m., never helpful. Whoever you are, it's never helpful. So, and also, contacting the hotel, emphasizing that you're doing a crucial exam for your career in advance to find a better room for you is actually helpful. And usually everyone will help with that.
Yeah, I mean, people are different, obviously. So I think most of us would like to be staying in a quiet room for good sleep. But I understand some people maybe want to stay with friends just to, help them to get through the night, the difficult night. But I mean, up to you, but think carefully about the night before the exam. That's mainly the plan, how it's to help you optimize your performance next day.
That's definitely.
it is, you know, unfortunately, difficult day and one of the most important days of your life. So you need to plan it.
And as I said,
you use it. Make sure you use your pencil. You draw big diagrams that they can see properly. Use the entire sheet. Don't take shortcuts, because a simple, quick diagram can actually get you the marks before you even start talking, because you probably covered the topic. For example, things like bending of arcades in cartilage and so on. As soon as you draw that, the examiners know you're in the right way, and they're just going to relax.
And you know, take history with special emphasis on important stuff that would affect your management. Yeah.
Yeah. I think it's important. Like that's why we're doing all this preparation. I agree with this principle. Swiftly move on to the scoring points within 30 seconds. If you take in more than 30 seconds to move to scoring points, you're losing the chances to pass the exam. If they put anything of you, you should know straight away what they want. Yeah? If they put a child X-ray in front of you, femoral shaft fracture like Mohamed showed, they want you to say non-accidental injury, so you should say it straight away. But then they want you to move quickly to the management of this femoral shaft fracture according to the age of the patient. So there's no point, you know, wasting a lot of time on asking a lot of questions. Move quickly. They want to discuss the management of this. Get to the management within the first 30 seconds. After 30 seconds, that's it. And then they will ask you after that, you know, whatever about, you know, they will be bored and they want to sometimes just ask you very high advanced questions once you pass. So, yeah, move swiftly to the scoring points.
And for me, I have to support both Firas and Mohamed, not of the mentors on one of the questions asked by Atif. He was told not to use eponyms. What are your opinions, guys?
I personally don't like eponyms very much. However, you cannot resist saying Mantegia and Galeazzi for these forearm fractures. I mean, but I personally, when I'm on the spot, I struggle to remember all these eponyms and classifications. So I normally describe what I see. However, if it's something well known like Mantegia and Galeazzi, and you know, you've got to know it and say it. I don't think there's anything wrong with that. But don't go into some eponym that's, you know, very rarely only for super specialized people will know. But I don't know, Mohamed, what do you think about this?
I agree with Firas. I think what you've said, you know, as I said, you know, you're a consultant. It's like in a trauma meeting, you wouldn't say this is a fractured radius with dislocated, you know, or this is a fractured radius with dislocated distal ulnar dislocation. But you would say eponyms that really well known. You know, I would do so because it's a discussion, and I don't think there is right or wrong here. But if it is well known eponyms, as Firas said, I think I should say it. But you know, don't dig yourself a hole in other less known stuff. But for Mantegia or Galeazzi, I think I would say it if I remember it. If you think, you know, because here it's very easy to say it, but on the day under the spotlight with pressure, if you're not sure, just stick to the basic principles. What you can see, I can see that. I'm worried about dislocation 0 Z. That's what I would do.
And Kashif, what do you think?
Yeah, I think I fully agree with Firas and Mohamed. You need to mention the most common ones, but not the rarest one, because then you are digging a hole for yourself if you're mentioning the rare eponyms. But the common one which we see in our daily practice, you need to know, and probably the best you need to mention. The common one, but not the rare one.
For my money, I agree. Don't use the rare ones, but I think eponyms are very useful.
Yes.
You're stuck trying to remember the eponym. Just leave the word block alone. Just move to describing, as Mohamed has said, describing what you see, and Firas have said. But the reality is, for me, the word Mantegia conveys an immediate picture of an X-ray that I know in my head what it is. Yes. If someone says Lis Franks, I now know exactly what this person is worried about and thinking along the lines. If someone says Jones fracture, it's in my head. However, if you say something like Jones fracture, it's wrong, and it's not actually the junction of diaphysis and metaphysis, you're in trouble. because
Yes.
you need to understand what exactly that eponym is referring to.
And then
Always good to say because there's a radial head dislocation, because there's a ulnar ulnar dislocation at the wrist, or because this is a fracture at the diaphysis and the metaphysis junction, which is the